طلابنا الأعزاء السلام عليكم. Our lecture today about strabismus. We will define few terms. Orthophoria. Orthophoria means perfect ocular alignment in the absence of any stimulus for fusion, which is uncommon. Heterophoria means tendency of the eyes to deviate when fusion is blocked, which means latent strabismus. Slightphoria is present in most normal individuals and is overcome by fusion reflex. Heterotropia, which means manifest deviation or sequent. The extraocular muscles, there are 6 extraocular muscles: 4 recti muscle, medial rectus muscle, and lateral rectus muscle, superior rectus muscle, and inferior rectus muscle. And there is 2 oblique muscle, which is the superior oblique muscle and the inferior oblique muscle. The innervation of these muscles, the third cranial nerve responsible for the innervation of the inferior rectus, medial rectus, and superior rectus with inferior oblique muscle. Fourth cranial nerve responsible for the superior oblique muscle, and the sixth cranial nerve responsible for the lateral rectus muscle. 5 muscles except the inferior oblique are originated at the orbital apex here from the annulus of Zinn. Position of the gaze. There are 9 diagnostic positions of the gaze, those in which the deviation are measured and we can diagnose patient with strabismus. A primary position, which is here, the primary position of the gaze: elevation, depression, dextroversion, levoversion, levo-elevation, levo-depression, dextro-elevation, and dextro-depression. The primary position of the gaze is defined as the position when the eye and head are both directed straight ahead. There are 2 strabismus adaptations. One is sensory and the other is motor adaptation. The sensory adaptation means the ocular sensory system in children has the ability to adapt to anomalous status, which is either confusion or diplopia, by 2 mechanisms, either separation and abnormal retinal correspondence. While the motor adaptation, which means adoption of an abnormal head posture, like face turn, head tilt, chin elevation, or depression. This picture shows face turn, and here is the head tilt. Amblyopia. It is the developmental defect in the central visual pathway, result in unilateral or rarely bilateral decrease in the best corrected visual acuity, for which there is no identifiable pathology of the eye or visual pathway, which means absence of organic lesion. The causes of amblyopia either strabismus or anisometropia, which means difference in the refractive error between the 2 eyes, which means one eye may have myopia and the other hypermetropia, and else. Third cause of amblyopia, stimulus deprivation, which means opacity in the media, like in case of total congenital ptosis or congenital cataract. Fourth cause, bilateral ametropia, which means high symmetrical refractive errors and usually high hypermetropia, which give rise to bilateral amblyopia. Diagnosis. First of all, there is difference in the visual acuity between the 2 eyes by 2 Snellen lines. Second, by the crowding phenomena, which means reading single letter more clearly than reading multiple letters. Treatment of amblyopia. To note here, the sensitive period during which the visual acuity of an amblyopic eye can be improved is usually up to 7 or 8 years. And correction of significant refractive error is an essential preparation for active amblyopia treatment. The treatment of amblyopia by occlusion or patching of the better sighted eye is the most effective treatment. And if there has been no improvement after 6 months of effective occlusion therapy, further treatment is unlikely to be fruitful. Second line of treatment for patients with amblyopia, by penalization, either by atropine drop or fogging glasses, which can be used for mild type of amblyopia, which means the visual acuity 6/24 or better. Can we use low dose of oral levodopa have been shown to augment the effective of ocular or occlusion therapy. This picture shows how the patient with amblyopia can see the objects, here in case of weak amblyopia and here deep amblyopia. The other picture shows the occlusion therapy. Here is by patching of the better seeing eye, and here the fogging glasses for the better seeing eye. How we evaluate patient with strabismus, or the clinical evaluation of strabismus, starting with history. The age of onset is very important. Visual acuity and measuring the visual acuity according to the age, either pre-verbal children or verbal children, different, either illiterate patient or educated patient. Each one use a special type of Snellen chart. Third, by testing of stereopsis and 3-dimension. Test of sensory abnormality, and can we check the abnormal retinal correspondence. Measurement of the deviation by using Hirschberg test and cover test. Motility test is very important, and we can check if there is any limitation in the ocular motility in any gaze of or in any position of the gaze. Also, we use investigation of the amblyopia by his chart in case of concomitant strabismus or paralytic strabismus. Refraction is very important to exclude any refractive error, and fundoscopy also to exclude an organic lesion. Note: the earlier onset of strabismus, the more likely the need for surgical correction. This picture shows the different type of Snellen chart. Now we will discuss the most two common types of strabismus or sequence, the esotropia and the exotropia. Esotropia mean is a manifest convergent sequence, which means inward deviation, which is the most common form of strabismus. Either concomitant, which means same angle of deviation in horizontal gaze position, or concomitant, the angle differ in various positions of the gaze. Types of esotropia, either accommodative or non-accommodative. The commonest type of accommodative esotropia is refractive, which means the patient has hypermetropia between +2 to +7 diopter. That presented between the age of 18 months till 3 years of life. And the treatment is by glass or convex glasses. The other accommodative type of strabismus or esotropia is non-refractive, which means high ACA ratio, which may require bifocal glasses. The non-accommodative esotropia, and the commonest form of non-accommodative esotropia, is infantile or early onset esotropia, which characterized by presentation within 6 months of life, and there is no refractive error and no hypermetropia, large angle of deviation, and alternating between the two eyes, no limitation of ocular movement. The treatment of infantile or early onset esotropia, ideally by surgical correction within the age of 1 year, even though bifoveal fusion is not achieved, and sometimes may require further second session of surgical corrections. Other rare types of esotropia: microtropia, convergence spasm, sensory type, consecutive, 6 cranial nerve palsy, Duane syndrome type 1, and Mobius syndrome. This picture shown here is the infantile or early onset esotropia, and here is the accommodative or refractive esotropia. Show the child with the glasses, the eye are straight forward or straight ahead. There is a form or term named pseudo-sequent or pseudo strabismus. It is a clinical impression of ocular deviation when no sequent is present. The cause is either epicanthal folds, may simulate an esotropia as in oriental persons, or abnormal interpupillary distance. This picture shows child with pseudo-esotropia due to epicanthal folds. The other common type of strabismus is exotropia, which means divergent sequent or outward deviation. Its type either early onset or constant exotropia. It's characteristic by normal refraction, large and constant angle of deviation, and usually associated with neurological abnormalities. Treatment, as we said before, because it's early onset, treatment mainly surgical. The other common type of exotropia is intermittent type, which is presented around the age of 2 years. Exophoria break down to exotropia under condition of visual inattention or under sunlight. Treated either by using over minus lenses in glasses to stimulate accommodation and convergence with near exercise and training, or by surgical correction. Here, the exo deviation is rarely completely eliminated by surgery, and the result found to be unsatisfactory for the patient and for the physician also. Other rare type of exotropia is sensory consecutive Duane syndrome type 2 and third cranial nerve palsy. This picture shows patient or child with exotropia. There are multiple and other rare special types of strabismus like Duane syndrome, Brown syndrome, and Mobius syndrome. Duane syndrome means congenital anomalous innervation of the lateral rectus muscle by fiber from third cranial nerve instead of sixth cranial nerve. Brown syndrome means congenital mechanical restriction result in impaired movement of the superior oblique tendon through the trochlea. Mobius syndrome, which means multiple bilateral cranial nerve palsy, like bilateral seventh and sixth cranial nerve palsy. Paralytic type of strabismus, if there is a sixth cranial nerve palsy, give rise to esotropia. Third cranial nerve palsy give rise to exotropia, and the fourth give rise to hypertropia. And here is fourth cranial nerve palsy show right eye hypertropia, elevated upward. Surgery if required for patient with strabismus. Its indication to improve appearance and if possible to restore binocular single vision, and also be used to reduce an abnormal head posture. Type of surgery either weakening procedure like recession or strengthening procedure like resection of the muscle. Vector adjustment, which means transposition of the muscle. Notes. Surgical results vary depending on criteria for success and length of the follow-up. Cosmetic success is often defined as an esotropia or exotropia of less than 15 present diopter, and functional success is often defined as a small asymptomatic phoria less than 10 present diopter. Surgical success rates are dependent upon many variables, some of which are unique to a given clinical situation. Patients who undergo surgery attain their final alignment within 1 to 6 weeks after surgery. Type of surgery, as we say, either resection of the muscle, cut the muscle and recess, or resection of the muscle, cut piece of the muscle and re-anastomosis again. In all our lectures, our reference is Kansky textbook, and thank you for your listening.